coming back from abroad to right back here to York University, one of York University's finest scholars, Pat Armstrong.
I'm standing up in part because it's nap time. And although that was incredibly energizing, I have to say.
It's in the morning.
But also I wanted to get away from the halo. It felt a little much to be sitting in the halo. I thought of all of the good things about Leo would have been said by now, even though, of course, there are an awful lot of them, by the time it got to this stage in the conference. But I was surprised that more hasn't been made of the central role that Leo played in studies in political economy, which is one of the many places where I personally have benefited from his very sharp intellect and his commitment to community. So I think it's really important for us to recognize SPE and how much that is Leo's product. But recognizing that he's a realist with imagination, and based on my personal experience, I thought I could add that I know for many New Year's Eves spent with Mel and Leo, that their revolution will not only include the good debate, the good wine, the good food, and the good jazz that we've been hearing about, but also good dancing. And that's the revolution I want to be part of. In preparing for today, I started by reading the 1977 article and then went on to the 2017 article. And I was really impressed, as I was telling Leo the other day, by how much continuity there is between these two very distant, in terms of time, articles. It's very impressive. I'm not sure I could say that about my own stuff. In fact, I'm afraid to go back and read a lot of it. But I would like to think that if he's going to do a new version of the book on the state, that it would have more than 2 articles on women and more about women and other social relations. And in fact, I'm convinced that he would do so. In his 1977 article, Leo tells us that one thing a theory of the state must do is, quote, demonstrate concretely the linkages between the state and the system of class inequality in society. And I would complement this by, from the 2017 article, by his revolutionary optimism of the intellect. I want to do a bit of both today by focusing on Canadian healthcare. It's a place where states and global markets so obviously intersect these days, as the morbid symptoms issue of the register make clear. And it's a place where Canadians have experienced at least a glimpse of how each, according to their need, could work. Several decades ago, Canada's healthcare system was described in trade discussions as an unopened oyster, ripe for extracting the pearls of profit, especially when investors were running out of other places to invest. Most recently, the focus is more on care for seniors. We're learning, just like we used to about poverty, that there's a lot of money in poverty, there's a lot of money in seniors. As the Globe and Mail Report on Business headline put it, as boomers age, a booming sector emerges. And certainly we're seeing dramatic increases in profits and the consolidation of corporate chains in this area. At a meeting organized by the Canadian Medical Association and some large corporations several years ago, attendees were told that the greatest obstacle to profit making in Canada and the healthcare system was public support for public health care. The support came because the socialization of costs and the decommodification of care worked for many. It did not create a perfectly equitable system, but it did go a long way towards creating a system where women especially found decent work, largely as a result of the unionization, which in turn was the result of their congregation together in public workplaces, and where access to acute care was based on need rather than on ability to pay. Our system has, however, at least 2 fundamental weaknesses that leave it open to undermining by the search for profit. First, the public part is based on what the people in the US call a single-payer system. We can describe it as a socialization of payment, but not of delivery. Most services from doctors and hospitals are paid for from the public purse, and coverage is universal and without fees for Canadians and those with landed status. But the delivery is private, although not primarily for profit. The Canada Health Act, the federal legislation that sets out the principles for public care, left the delivery by mainly not-for-profit hospitals and by doctors in private practice intact. The Act, however, does not prohibit for-profit delivery, only requiring non-profit administration of the public insurance plan and prohibiting additional fees when doctors provide a service that is already covered under the public plan. The second major weakness in Medicare is the restriction of universal services to doctors and hospitals. On the basis of evidence produced in public hearings, the 1964 Royal Commission on Health Services concluded that covering the full range of services was the only logical and money-saving way to coordinate services, ensure people were receiving appropriate care, and eliminate the need to sort the deserving from the undeserving. But the federal government decided it would start with hospitals and then doctor care before moving on to other services. It never happened. By starting this way, it gave individual doctors and hospitals significant power in ways that make it difficult to control what gets done by whom at what cost, and that limits the capacity to collectively coordinate services to reduce wait times, or to locate people in appropriate services, or to limit a move to profit, or to more democratic organization. So you can see that the system has led a lot of room for oyster shucking and for the undermining of public support. In recent years, governments at all levels have been handing for-profit providers the knife. They've been doing so in ways that are familiar throughout the public sector, contracting out services and applying for-profit managerial strategies to what remains, introducing managed competition for a range of services along with for-profit delivery or public-private partnerships, and doing so in ways that provide an affirmative action program for large corporations. Patients and residents become customers, and instead of accountability through democratic decision-making of the sort Leo calls for, there's technocratic auditing from above of the sort that Power talks about. Bureaucracy increases, as Leo has also warned. In healthcare, these pro-corporate strategies have been combined with reduced funding for public services and the failure to provide for new services under the public plan. Some of the consequences are also familiar across public services. Costs are shifted to individuals, space is created for for-profit alternatives, public expenditures rise, and working conditions deteriorate along with services. Unions are challenged or even assaulted, to use Leo and Donald's term. Inequality increases. Some consequences are more specific to healthcare. Wait times for services, for example, increase along with further fragmentation. Women make up the bulk of the paid labor force and of those who provide unpaid care, so they feel the greatest impact. They also use healthcare more, mainly because they live longer and because of reproductive services, so the decline in services has a greater impact on them. Some of the justifications are familiar as well. The market's more efficient and competition ensures quality at the lowest price, being the most obvious justifications. Austerity is necessary and the private sector will bring in much needed cash is another frequent claim. The weaknesses in the systems have helped provide the space for these strategies. The separation between purchaser and provider, along with the mixed public-private distinction, make it difficult to organize around privatization because those searching for profit claim the system is already private, without, of course, making a distinction between those who seek a profit and those who do not. With the government still paying, it's hard for people to see what the problem is with handing over care delivery. At the same time, the restriction of universal coverage to hospitals and doctors leaves lots of room to insert for-profit delivery as well as fees. The lack of coordination, combined with public funding cutbacks and shortfalls, increased the wait times that receive so much attention, although not nearly to the extent that the media and the corporate sector would have us believe. But the public support for Medicare means that privatization has been mainly by stealth and has been justified primarily as a way to save public health care. New Brunswick's health minister made this clear recently when he announced that a for-profit firm will take over a home health program and the home health advice line. He awarded the contract without a tender and did so for 10 years and only with an estimated cost. But he claimed, and this is a quote, "This doesn't mean a privatization of any health care because nursing and telecare will continue to be free for patients and paid for by the province," end of quote. He went on to claim while it will cost more initially, it will save in the long run and lead to better coordination of services, based on faith, of course. And he promised that jobs could be saved, reflecting the still strong unions in this sector. Similarly, when opposition arose to the purchase of a majority stake in BC's retirement chain by what the Globe and Mail called, quote, "a massive Chinese insurance company with a murky ownership structure," which is interesting given what you were just saying, Sean, the government defended the sale by arguing that quality would stay high because the former owners would continue to run the homes and would, quote, "maintain at least the current levels of full-time and part-time employees." However, later the government added that this commitment was for only 3 years. For the more cynical among us, the Globe and Mail's comment that, quote, "makes it even more attractive is that it also owns holdings of unused or partly developed land that would allow a major expansion of facilities in the future," end of quote, suggests that it's real estate and not the services that are the attraction, as we've heard from several other people already today. Reforms have also been justified in terms of progressive ideas. The closure of psychiatric, rehab, and chronic care hospitals were justified in terms of critiques of institutionalization, even though few alternatives are provided. Shorter patient stays were justified in terms of reduced risk, healthy childbirth, and technological advances, even though as soon as you leave the hospital, you can be charged for many aspects of care. Care at home is claimed to be the first choice of all, ignoring the burden on unpaid care work, the fact that many have no safe, healthy homes, or that many homes are not havens in the heartless world, as feminists have long pointed out. These justifications, too, may be hard to counter because, as Trump has recognized, it's complicated. There is still widespread support for public care. More than 85% of Canadians say that they support public care. Multiple researchers are documenting the consequences of marketization for costs, equity, quality, the health of healthcare workers, and access to care, providing the kind of evidence Leo calls for in that 1977 article. They're doing so in terms that can be understood by a wide range of those who need health services. They are challenging the claims of the government, questioning the role of markets and rejecting profits in care. Health coalitions and unions have been working hard to resist, as in ways similar to what Ursula was talking about this morning. But we need to develop more revolutionary reforms, ones that address the weaknesses in the system and that offer both structural and process alternatives while building on the public support for public care. As we argue in our current research project on long-term residential care, the conditions of work are the conditions of care, and those conditions have to be addressed through the multiple layers that reach from the local to the global. It means addressing internal hierarchies, some of which are supported by unions, and taking gender as well as other social relations and inequity into account. As we've shown in our project as well, scandals have mainly resulted in more regulation of workers rather than in the regulation of capital. And regulation by the state cannot be our primary strategy in this area. And we need to tackle the thorny question of bureaucracy that Leo raises again in the latest register. We also have to identify the contradictions he emphasizes and confront the fact that some of the unions have an investment in for-profit care. For example, Rivera, a private nursing chain, is 100% owned by the Canadian Public Sector Pension Investment Board and is heavily involved in real estate investment trusts. I have many more questions that I have answers, but I do think we need to be asking them of ourselves and together here. And I'm also aware that the kinds of things I'm talking about in terms of offering public health care also are full of contradictions. Healthcare can show how socialism could work, albeit in one service it's not fully socialist. And we always used to say you can't have socialism in one building. We can also use it to demonstrate how the search for profit and the reliance on markets does not work, providing some basis to offer, to quote Leo, a way beyond them to secure equality, to realize democracy, and to achieve social and ecological justice. Thank you.
Thank you very much, Pat.